Good afternoon, everybody. My name is Jessica Cecil. I'm the Education Coordinator at the National Aging Research Institute. Welcome to our online Seminars in Aging program. I'd like to begin by acknowledging the traditional owners of the land on which each of us is meeting today, and to pay my respects to their elders, past, present, and emerging. Firstly, a little housekeeping regarding Zoom. At the conclusion of the talk, we'll have some time for Q&A. If you have any questions, you could submit them throughout the seminar using the chat function, which can be opened using the chat tab at the bottom of your screen. So today we'll be hearing from Professor Colette Browning. Colette is Professor in the Health Research School of Health at Federation University Australia and is an Honorary Professor in the Research School of Population Health at ANU. She's a recognised national and international leader in psychology and health, and her research focuses on healthy aging, chronic disease management, and consumer involvement in healthcare decision-making. Today, she'll be presenting sensory loss and quality of life in older people. So welcome, Colette, and over to you.
Thank you so much for a lovely welcome. I'd like to acknowledge the traditional custodians of the land on which we're meeting today. And for me, it's the Wurundjeri Woi Wurrung people, and pay my respects to elders past, present, and emerging. And thank you for inviting me to give this talk today. It's an area that myself and my colleagues have been working on for a number of years, but it's only, I suppose, in the last few years that it's gained some traction in terms of an important issue in aging. So I think we'd all agree, given that probably the people on board are working in the aging field, that population aging is actually a success story. However, there are a number of challenges associated with population aging, and as clinicians who may be present, you would know that often you're dealing with older people who have a number of chronic conditions that they need to manage, and that these chronic conditions impact on their quality of life. And for individuals, obviously that's important too, that most people want to have the best life they can. And even as they age with a chronic illness, they want to maximise their quality of life. In terms of chronic conditions, there's often a focus on mobility issues, dementia, urinary continence in older people, and age-related sensory loss is often under-researched compared with how we research and provide services for older people. But what we do know is that sensory loss does have a significant impact on the quality of life of older people. And there are things that we can do to prevent sensory loss and also to manage it as we age. So what I'm going to talk about today, it's sort of a couple of different things. I'm going to just give you a sort of snapshot of the prevalence of sensory loss, and particularly looking at dual sensory loss, because this is the main research myself and my colleagues have been doing over the past probably 10 years or so. Look at the impacts of dual sensory loss and look at some studies that we've just been funded for that are just about to commence. And also, I've done a lot of work on dual sensory loss in China, so I thought I'd give you a bit of a comparison there about what are some of the issues in China in terms of dealing with sensory loss in older people. So before I go on to this particular slide, I also wanted to acknowledge that my main collaborator in this area is Professor Cherise Heine, who's an audiologist, and she actually started her PhD in this area, and at the time hardly any research was being done in sensory loss in older people. So she's been a pioneer, and we've worked together over the years, and we currently have a new student, Shane Lake, who's also doing some work in this area, and I'm going to talk a little bit about her work as well. So first of all, we all like to know, what's the burden, I guess, of various conditions. There's not a lot of up-to-date data in Australia, recent data on this, but from the AHW's report in 2018, looking at chronic eye conditions, we can see that chronic eye conditions are quite a significant issue for older people. So when we're looking at the sort of 55 and over, for both men and women, it's up around 90% of people will have some form of eye condition, which needs some correction in some way, usually through for the majority of people, it'll be just to have good glasses, but for other people, they may have serious eye conditions that require surgery and more interventions in terms of treatment. In terms of hearing loss, it's not as prevalent, but as you can see, increases quite dramatically across the lifespan. And once we get into the old, about 58% of people over 85 actually have a hearing loss. So if you combine this with vision problems, that can be obviously have an impact on people's quality of life. In terms of dual sensory loss, so this dual sensory loss is defined as an acquired loss, so not people who are necessarily born with dual sensory loss. This is often referred to as deaf-blind. If you're born as and have early in life these problems. Dual sensory loss is more defined in the literature as an acquired loss, and it can vary in terms of the severity of the vision loss and the hearing loss, and it's associated with aging, obviously. So we conducted a review a few years ago to look at what was the prevalence of globally of dual sensory loss. And interestingly, when we looked at these studies, they range from 3.3% to 64%. Now, in terms of trying to get a handle on this, that's a big range. And what we really found there was that it really depended on the type of study being reported. So population studies tended to report obviously smaller prevalence, whereas clinical or health service studies where people were turning up to get treatment reported higher prevalence. The other very important part of this is that we've used different assessment methods to measure dual sensory loss. So there are clinical measures like audiometry and other types of measurement of vision versus self-report measures. And they often give very different measures of sensory loss. And so when you then combine them into trying to estimate prevalence of dual sensory loss, it can be quite tricky. One study that was done that really used a fairly large population survey, the Australian Blue Mountains hearing study, which was an offshoot of the Australian Blue Mountains eye study, estimated the prevalence to range from about 5.5% in the 70s group, but then really rose quite dramatically in those over 80 to about 27%. And that's probably one of our best estimates, I think, in Australia of dual sensory loss. Now, obviously, as I mentioned earlier, sensory loss is going to impact on how we live our lives, on our quality of life. And there's lots of studies that have shown it impacts on how we go about our normal life in terms of our activities and of daily living and instrumental activities of daily living. Obviously, communication is an issue. If you've got both a vision and a hearing loss, you can't rely on one or the other to help you with communication. So that becomes quite difficult. We also know there are links to sensory loss and dementia, impacts mental health and well-being, how we interact with people, and also in terms of our physical activity, because if we've got some severe sensory loss, it makes us difficult to get out for a walk or engage in activity. I'm going to focus on the three highlighted in blue today, just to give you a bit of a snapshot of where these impacts are. So cognitive impairment and sensory loss. This has become a hot topic, and we've found in a number of studies associations between sensory loss and cognitive impairment and dementia. And one of the most recent studies was interesting, was a prospective study of sensory loss. This is a US study of people receiving Medicare interventions. And what was found there was that there were impacts in terms of vision and hearing and dual sensory loss, and how that impacted on the risk of dementia compared to those with no impairment. So it's interesting that, and how, that sensory loss, and this is a longitudinal study, so it's looking at a solid pathway there around sensory loss impacting on dementia. And there are different ways that we can interpret this. It could be that if you've got sensory impairment, you're more socially isolated, you're, then have mental health problems, you're less likely to be physically active, and all these things have been implicated in dementia. And the other way of looking at it too is that there may be similar disease processes involved. So cardiovascular diseases and neurodegenerative diseases may have, similar processes that are linked to the sorts of processes that are involved in sensory loss. And this is still a very active area of research, people trying to work out what those pathways are. Now, just in terms of recent research that's going to be happening soon in this area, Professor Piers Dawes at the University of Queensland has led a team which includes myself and Charisse from Federation University, where we're looking at how to support people with hearing and vision loss to improve the quality of life. And these are people who are living with dementia in residential aged care. So we're looking here at, I think it's a really interesting project that'll start next year, looking at co-designing a sensory support intervention with people living with dementia and residential aged care staff, as well as hearing and vision specialists, so that we can assist people living in residential care to manage their sensory loss better and help them with communication, which is very important. And this is an offshoot of a very large study in Europe, the SenseCog study in Europe, which is looking at supporting older people with sensory loss to improve their quality of life. So this is one that maybe next year you could get Piers to come back and talk about it, because it's a really interesting project. So the second impact I wanted to look at was mental health and well-being. And as I said, we have a student working in this area, Shane Lake. She's a PhD student, and she's just conducted a narrative review to look at the impacts of sensory loss on mental health and well-being, and also on social activity. So again, I've just highlighted a few of the publications we've been looking at. Those living with dual sensory loss show lower life satisfaction, lower positive, affect, more depressive symptoms than those living without sensory loss. There's increased risk of depression in people receiving home care who have DSL, and a rural study which we're interested in because we want to do some more work in rural Australia in this area. It's very under-researched. Higher rates of depression in those living with DSL in the community. And the one way of looking at how dual sensory loss might impact on mental health and well-being, as I mentioned before, you often get a breakdown in social networks if you have sensory loss, and more difficulty in communicating. So this it makes sense that this will impact on your mental health and well-being. So there's very limited research, however, done on these social networks and social participation of people with DSL, even though in terms of the gerontological literature, there's a heap of work on social networks and how important they are for older people. So Shane has just commenced her study in this area, looking at the social networks and the social world of older people living with DSL, and what are their aspirations and needs. And we're going to link this to the types of services that are being offered through home care, and look at the whether they match up and what sorts of new interventions and services might be appropriate for older people living with dual sensory loss. So just to sort of summarize, I guess, some of the main things that I want you to think about, particularly in Australia, DSL will increase in Australia with significant impacts on the quality of life, particularly as we get more people living into their 80s and 90s. Our services are quite poorly managed in a way. We don't integrate services well. We have health professionals providing services, for example, vision and hearing specialists, but they're fragmented. They often don't connect in with the social care services that are being provided. And this obviously means that people living with sensory loss really don't get the best value, I think, out of the services. And often there's not a rehabilitation focus. You know, for example, an audiologist might fit a hearing aid, but there's no ongoing assistance in rehabilitation, in helping people to use that hearing aid and work more on their communication issues. And this also links to training gaps at all levels of service delivery, that in most of the training of our health professionals and home and aged care professionals, we really don't talk much about sensory loss and what might be useful in working with older people. And that final point there really is about that even though often people might access aids and things like glasses, most people wear their glasses, but things like hearing aids, you often hear people get a hearing aid, never use it, and then they're not given any encouragement or education about how to use it to improve their communication. So again, this is the sort of thing that we'll be looking at in the Sense Cog project as well. Now, how am I going for time? Esther, am I going okay for time?
Doing all right, Colette?
Yeah, good. Okay, so now I'm sort of shifting gear because I want to talk to you about our studies in China. And I've been working in China probably, I don't know, for about 20 years now, mainly around the role of primary care in aging. So we've done a number of studies there around the management of chronic illness for older people. But what I want to focus on today is that we did some analysis of the China Health and Retirement Longitudinal Study, which is a fantastic resource of health data about Chinese people. And we looked particularly at the data that was collected on dual sensory loss in that particular study. So these were the sorts of measures that we used were mainly self-report measures, things like how good is your vision, how good is your hearing. And then we defined dual sensory loss as being fair, poor, or very poor in both hearing and vision. We're also looking at social participation in this particular analysis and looking at the types of activities that people were engaged in. And we also measured, excuse me, depression and looked at depression and satisfaction. This is one of my favorite pictures. This is 4 generations of women in China. The lady sitting out there looking back at the camera, we think she's well over 100 years, but because not good birth records aren't necessarily kept during that period for older people, but she's an example of healthy aging, where she'd go to the market every day and buy the food for all the family. So back to dual sensory loss. So interestingly, in the study with the Chinese, the dual sensory rates were very high. So if you remember back to my earlier slide, I think it ranged from about 5% to around 25, 26% in Australia, and that's probably true in Western countries more broadly. You can see that the rates are really high in China. And this is probably due to the fact that health in China, people rate their health much more poorly in China than they do in a lot of other countries. And in fact, with various health disparities like exposure to pollutants and occupational hazards, you often find that these conditions are more prevalent because of those exposures. And the Global Aging Watch Index rates China at 58 in the world, whereas Australia's sort of in the top 10. So I think what happens here is that the high prevalence of dual sensory loss is really a reflection of other poor health issues in China and issues around exposure to occupational environmental challenges that impact on sensory loss. In terms of social participation, we looked at whether DSL had an impact on participation. And what we can see here is that that having DSL did have an impact. So statistically, all those differences, some of them look quite small, but they were statistically significant. And this again is consistent with what we see in other studies, Western studies as well. We looked at the impact on depression and life satisfaction. And again, these were statistically significant. So people with DSL were more likely to be depressed, that their percentages in those in the table there were more likely to be dissatisfied with life. So their life satisfaction and mental health was compromised by DSL. The other interesting thing was we looked at unmet needs. Now, if you get diagnosed with a vision problem or a hearing problem, you can, in China, you can access services. You can get glasses, you can get hearing aids, but it's difficult because of the way the health system's set up. You often can't you have to have money to actually buy good quality hearing aids, for example. And what this figure really shows is that for those diagnosed with either a vision or hearing loss, the significant proportion of those people in the CHARLS study had unmet needs. They didn't have access to good hearing aids or glasses in order to deal with their particular sensory loss. And these unmet needs would be much higher than in Western countries and in Australia, particularly around the glasses. In terms of the hearing aids in Western countries, again, we have better access, but often people don't use them. So that's an issue more in Western countries of just not using the hearing aids that are available to us. So overall, if we think about China in terms of sensory loss, I think you can see from the prevalence studies that I've shown you that it's a very significant chronic condition in China with very high rates of sensory loss in both hearing and vision, and much higher than in many other countries. In terms of how the health system works in China, people mainly are seeing getting health services through the primary healthcare system, which is a pretty good system. But and recently in their policy reforms, they put an emphasis on the treatment and prevention of chronic diseases. But again, like in Western countries, sensory loss isn't necessarily seen as something to worry about. They're more interested in things like, diabetes and heart disease and dealing with those conditions in older people rather than things like sensory loss. And also, again, when you look at China, the training in these areas is pretty low. And there are very few audiologists that are actually trained and available to assist people with hearing difficulties in China. So again, I would say this is the same in Australia, that we need more training for our primary care health professionals and our aged care professionals in terms of sensory loss and what it means to older people, and training around what interventions can actually be useful for older people with sensory loss. In China, as I mentioned, there's a particular issue around the cost of aids for people. Most people assume because it's a communist country that sort of everything's free, but they have a more American style of healthcare provision, and they need to be part of and pay for a medical insurance scheme. And it's interesting when I talk to them about Medicare in Australia, they're quite amazed by that we have a more socialist system of providing healthcare than they do. So in conclusion, I'm hoping I've convinced you that sensory loss and especially dual sensory loss is an under-researched area, it's undertreated, and that we need to pay more attention to it if we want to improve the quality of life of older people, particularly in those very late years of life as people move into their 80s and 90s, and we'll have many more people in those age groups. So an obvious recommendation is to invest in prevention early in life. And what we really want as we age is that we've been engaging in preventive activities so that when we enter old age, we're in our best health possible. And there are things that have happened more, over the last 20 or 30 years around this. For example, in Australia, we deal with occupational noise quite well now. People have to wear, hearing muffs and things like that. So those sorts of occupational exposures are probably going to be less for people as they age, particularly, say, the baby boomers age. But it's still important, I think, when we're thinking about aging, to think about prevention earlier in life, and particularly around that middle age where probably people are open to prevention and it can still have an impact on our health as we age. The other thing that I think is just true across all aspects of the service industry in Australia, we don't integrate health and social care services very well. And I think this is particularly true with sensory loss. You turn up to your optometrist, your audiologist, you get care maybe in the home from an aged care provider. None of them integrate together, and so it's quite an inefficient system. But I think we could say that about a lot of the disconnect between health and aged care services in Australia. The third point I want to make there is about the training of particularly primary care professionals and aged care professionals as well. I'm at a university that trains a lot of primary care professionals, nurses, physios, you name it. And I think we need to include some of this material in their training so they're aware of how important dealing with sensory loss is as we age, and to provide appropriate services for older people with sensory loss. And the last point I've got there, and I could have done a whole presentation on this, about new technologies. And there's a lot of work going on at the moment in health technologies for older people, things like, robots and various things like that. And I think this is interesting and good. And for a lot of us, we like to embrace technology. But unfortunately, a lot of the work that's done in this area is done by people from technical backgrounds without much engagement with older people themselves. So I think in this area particularly as well, that we've got to look at, if we're looking at technological solutions to deal with sensory loss in older people, we have to really embrace co-design and make sure that the sorts of technologies we're developing to help people age well are actually going to be useful and will be adopted by older people. I think I've got the end here. I've just got a whole lot of boring references that I've referred to. So I'm going to stop sharing the screen now. Yeah. There we go.
All right. Well, thank you so much, Colette. We now have some time for Q&A. So if you have any questions, please submit them now through the chat function. Alternatively, if you'd like to ask a question in person, you can turn on your camera and microphone now, and we'll be able to call on you in turn. So I think we've got one question come through from Browning. She asks, one of the issues is convincing people to use their assistive devices, such as hearing aids, and getting health and aged care staff to pay attention to them as well, such as checking if batteries are charged and hearing aids and glasses are within reach.
Yeah.
Not more of a comment, but do you want to comment on that?
Yes, and I'd absolutely agree, Bryony. And I think what often happens, say,
sorry, that was a comment.
Hi, Bryony.
Hi.
Yeah, absolutely. And I think this is where we need some different approaches. Like often, particularly with audiologists, and my colleague Charisse, who I do most of this work with, is an audiologist, and she would be happy for me to say this, is that, you turn up at the audiologist, oh, here's your nice hearing aid, we'll do a bit of play around with it, and then off you go. And there's no follow-up, there's no rehabilitation type education about that. And it's just like it's like a marketing activity. Here's your hearing aid, off you go, and no customer follow-up, I suppose is what I'd say. And then, of course, you've got the situation in residential aged care where people, again, there are issues in terms of people being able to use their hearing aids and the batteries, all that sort of thing. So the SenseCog project that I talked about, that's the sort of thing we're going to be looking at in ResiCare around how to maximise the use of aids, but also working with the residents to work out what's going to work best for them in terms of assisting them with their sensory loss and their communication.
Yeah, I think and I think it comes back to your initial comments around it not having the profile of mobility and some of the other issues that older people experience. I don't know why, because it is so prevalent.
Yes.
That we don't think about if somebody seems to be having difficulty understanding, maybe they're just not hearing, or So yes. I think it's and the other comment I'll mention before, so it just doesn't have to read it out. It's just that I agree with you about the technology. I'm sure there's a huge role for technology here, but it does need to be co-designed because, well, similar to what I was just saying, that people have got to use their hearing aids, so they've got to like them, they've got to be familiar with them, they've got to be able to manipulate them. There's a whole range of things that I don't think have really been thought about enough with older people. So yeah, just agreeing with you there around co-design.
Yes, Francis also comments that the look of many assistive technologies are often very unattractive.
Yes, yeah, absolutely agree. And and that's sort of, it's interesting that, because what you've seen, say, in the hearing aid area is that they've got smaller and less obtrusive, so that the ones that were there 30 or 40 years ago have sort of gone by the by. But again, those ones that are the more high tech are often very expensive, and that's particularly an issue in China about getting hearing aids that are the high tech ones. But also here, I mean, we have a lot of older people who are on pensions. They can access the Australian hearing service, but again, and I'm not absolutely sure about this, but I'm sure it's not the highest tech ones that are being offered there. And I think it's just it is an issue around how to make technology more accessible, because I think we're in this era where we think technology is going to save everything, and maybe it will at some level, but unless we design these products that that are going to be used and are desirable for people, then there won't be an uptake. And if you look at it from an economic point of view, you'd think, well, it sounds like a no-brainer, because that's how most products work, that if they're not attractive and usable, people don't buy them. But I think there's a lot of stuff being developed without that in mind.
Sue, do you have a question for Colette?
Yes, I was just asking Colette to perhaps think about how programs are delivered. So as someone who has, as a therapist, a physiotherapist, many of my, what's seen as Bryony said, the important thing, like mobility, you spend half your session finding the hearing aid or the glasses so that they then can participate in the thing that has the value. So I'm just wondering if the preparation for the things that are seen as most valuable have to include that preparation time of getting ready to go for your physio by making sure that you have addressed your sensory loss issues in whatever way, and how, for example, I mean, in the rehab setting where nurses make sure people have their pain medication at the appropriate time before their therapy or in aged care, but also making sensory compensation kind of strategies, assistive technology incorporated in that kind of thinking as well.
Absolutely agree, because as you say, it's sort of a waste of the time you've got to actually do what you need to do as a physio. And again, I think this is something, again, to the way, we set up our systems. They're very siloed. So coming to the physio today, I'm thinking about, oh, well, have I got my tracksuit on and my right shoes or whatever? And maybe, not not thinking about that. Well, am I going to be able to hear or whatever? And also, I suppose when you get there, you often have a bit of time to wait. Is there an opportunity then for, say, someone who's someone else's there, is to make sure the person is ready, as you say, check that their hearing aids on and all that sort of stuff before they actually get into the physio. So that's around the system and how you organise it, I guess, within your practice too. Yeah.
Thank you for asking that question, Sue. We have a comment from Felicity. She says it's also very easy to lose hearing aids. They can fall out or get misplaced. The cost can make people think twice about using them if they're concerned they might lose them, especially with wearing masks. Easy to catch the hearing aid and flick it out.
Yeah, all very good points. Agree.
Kirsten asks the next question. She says, thanks, Colette. Will you also be looking at the environment in the residential aged care setting product, such as lighting and noise and other factors that may impact vision and hearing?
Yeah, absolutely. And that's a very important aspect of all communication, that, if someone, let's say you don't have dual sensory loss, and in fact, the cogs, the sense cog is not, it's about hearing and vision, and some people will have both. So, in any sort of environment where people are living, you need proper environmental, you need the environment to be conducive to communication. So you need good light, you need, to try and reduce ambient sound and things like that. And again, I think it's difficult in residential aged care to be able to do that. But again, it's something that we will be looking at. What are some sort of cost-effective ways of creating environments where communication can actually be maximised?
Thanks, Kirsten, for asking that question. I'd be very interested in a couple of follow-up questions about your SenseCog project. First of all, I think it's fantastic that you're involving people living with dementia in a co-design study. I know that it takes a lot of extra effort to be able to do that, but it's a very important population to include. About your methodologies specifically, are you using like a one-on-one interview approach with people living with dementia, or involving them in co-design workshops? What's your plan for engaging people living with dementia?
Yeah, well, in the application, we sort of looked at sort of different methods, and I think we're going to have to trial some different methods with that. And that's really, in a way, all part of the co-design process, isn't it? That you can't necessarily go in with a fixed idea about how it's going to be set up. And I think also if other caregivers are involved, how we might involve them in the process as well. Because again, I think caregivers want to be able to communicate well with their people who are in residential aged care who they're visiting. So I think that's part of the equation as well, because they'll need to be trained up as well. It's not just the staff who are going to want to communicate better and the residents who want to communicate better, but also the people, the carers from outside who are coming in, and they need to be part of it as well. So I think this is going to be an unfolding method, I would say, Jessica, about how we do that. We'll be, try different approaches, and it will depend, obviously on the degree of, dementia and communication issues that people have, and their degree of sensory loss as well. It may vary depending on, it will vary depending on who we're interacting with.
Well, thanks for that. And we've got another comment from Kirsten. She says, just FYI, there are home visiting optometrists available who bulk bill. I had a great experience recently with one who not only assessed the client's eye and vision, but also improved lighting. Great service.
Excellent. I like to hear that.
Good stuff. Well, if there are no more questions for Colette, everyone, please join me in thanking her with your clap reactions.
Thank you. And thank you for listening to what I had to say. And I'm sure, I'm hoping I've convinced you about the importance of sensory loss and aging.
Well, thank you so much for coming and speaking to us today, Colette. Everyone, next Tuesday is Melbourne Cup, so we'll be taking a break from seminars in aging, but we'll be back the week after on Tuesday, the 9th of November, with a presentation from Dr. Alex Baha-Fuchs. So thank you all for attending our Seminars in Aging program.
And wait, before you go, just one thing, we've got a annual summit on the 5th of November coming up, which hopefully you've all already received some notification about. And that's going to be on intergenerational relationships. So starting with some discussion around the economic, social, political debates with an economist, with Don Edgar, who set up the Australian Institute of Family Studies, and then talking about various programs, including the research behind Old People's Home for 4-year-olds. So that's a morning event, and you're all very welcome to attend. And Esther or Jess will send out more information to you all. Another reminder, you've probably already got one, but thanks.
Okay.